Okay, so let's move on and talk about respiratory failure from an assortment of causes. So respiratory failure just means I either can't ventilate or I can't oxygenate my blood, right? So it could be a problem with the chest wall, it could be a problem with the trachea, it could be a problem with the bronchial tubes, it could be a problem with the alveoli, all over the place. It just means that the respiratory system is not able to continue oxygenating the blood and also to clear the CO2 from the bloodstream. Okay, so acute respiratory failure, as I mentioned before, is I have difficulty ventilating my lungs. So that's the movement of the chest wall and with the lungs moving with the chest wall. So something is happening where I just can't ventilate. So, for example, that could be severe asthma or severe COPD where the bronchial tubes are filled with mucus and they just can't get the air to the alveoli. Or there's something wrong with the chest wall. They have Guillain-Barré syndrome. They have myasthenia gravis. They have something that's stopping them from the ventilation process, right? And ventilation just means getting the air from your mouth to the alveoli. And that can cause respiratory failure. Okay, a flail chest would be an example of inability to ventilate. What about inability to oxygenate? Okay. What about congestive heart failure leading to pulmonary edema? So now you have fluid all in your lungs. Okay. How are you going to get the oxygen from the alveoli to the capillaries? That's an inability to oxygenate the blood. Okay. So you can see that basically any disease that interferes with ventilation or oxygenation, um, meaning diffusion of gases across the alveoli, can lead to acute respiratory failure. Okay, so if you were to ask me, is asthma a problem of ventilation or a problem of um, diffusion of gases across the alveoli? It's a problem with ventilation, right? It's bronchoconstriction, and you can't get the air to the alveoli. Okay, is a pneumothorax a problem with ventilation or a problem with diffusion? Well, it's a problem with ventilation because you can't get the lung to expand, so you can't ventilate it, right? Um, and it's also a problem with diffusion because the whole lung has completely collapsed. Okay, so we'll come back to that. So it's basically all the many respiratory diseases can result in acute respiratory failure, needing intubation and ventilation. Acute respiratory distress syndrome is a condition where, um, remember, the capillaries in your lungs become very leaky, usually from a systemic disease, whether it's burns, pancreatitis, any severe illness that causes a lot of inflammation can cause the capillary beds in the lungs to vasodilate and become leaky. And now, when they're leaky, they're leaking fluid into the lungs, and patients are developing pulmonary edema. So they get stiff lungs. It's really hard to take a breath in, okay, with acute respiratory distress syndrome. So someone can come in with a completely separate illness, and they can develop ARDS because of that severe inflammation that they have. Okay, so they have difficulty ventilating, they can't oxygenate because of all the fluid that's in their lungs, and they may end up on a ventilator. Okay, severe acute respiratory syndrome, SARS, is a virus that in the early 2000s that came through, and it led to acute respiratory distress syndrome, right? So I don't think we need to spend too much time on that. That was a particular virus um, that was causing this respiratory distress syndrome. I mean, if we're talking about something more recent, COVID can get into your lungs and cause a severe inflammatory response leading to ARDS, acute respiratory distress syndrome, where your lung is filling with fluid from all the inflammation, and you end up on a ventilator. Okay, and that's how many patients have died from COVID due to ARDS. So in your book, you're going to see that acute respiratory failure has actually been separated into ventilation diseases and oxygenation diseases. So failure of ventilation or failure of oxygenation. So let's just look at a couple. COPD. Well, COPD, if you have a lot of chronic bronchitis and mucus in your airways, you can't get the air to the alveoli. So it's a ventilation issue. Now, it could be an oxygenation issue as well because you have alveolar destruction. So in fact, COPD is a mixture of a ventilation problem and an oxygenation problem. Okay, let's look at flail chest. Well, a flail chest is difficulty ventilating because part of your chest is loose. It's a separate segment, so you can't ventilate properly, right? What about asthma? Well, asthma is in the bronchial tubes, right? Severe narrowing of the bronchial tubes leading to a ventilation problem. Let's look at a couple of oxygenation issues. Pneumonia. Well, pneumonia is fluid and pus in the alveoli. So there's no problem with the ventilation initially. It's all about I can't get the air across my alveoli to get into the bloodstream. I can't get the oxygen there. So it's an oxygenation problem. What about pulmonary edema? Well, pulmonary edema is an oxygenation issue. I can't get the oxygen from my alveoli into my bloodstream. Okay, so keep the two separate. There's the ventilation, and then there's the oxygenation that occurs at the alveoli. Okay, and sometimes there's a mixture of both of them that are occurring. Okay, so what will someone with acute respiratory failure look like from any cause? Well, let's just choose a cause. How about severe pneumonia on both sides of your lungs? So the alveoli are just filling with fluid and pus on both lungs. You're going to be short of breath. You're going to be cyanotic, so reduced O2 saturation. You're going to be hypoxemic, right? Again, reduced oxygen saturation in the blood. You're going to be building up carbon dioxide in your blood, okay? Tachycardia, yeah, the heart's going to be pumping fast because it's low on oxygen, so it's beating faster and faster to try and at least pump as much oxygenated blood out as possible. Confusion because you're hypoxic, right? Agitation and restlessness, yeah, your brain is getting really nervous. You're hypoxic. Adventitious breath sounds, so basically any extra sounds in your lungs. Sure, you could have wheezing with asthma. You could have crackles and crepitations with pneumonia. You could have crepitations with pulmonary edema, with fluid building up in both lungs. So it just depends on the condition. Okay. ARDS, just think of it as I have fluid leaking out all in my lungs from some kind of systemic inflammatory condition. Okay, so am I going to be short of breath? Dyspneic, yes. I have fluid leaking out all in my lungs, pulmonary edema. Notice they say it's not from the heart, non-cardiogenic, right? Because it could have happened from any other illness, such as burns or pancreatitis, or, okay? Reduced lung compliance, yeah, the lungs are filled with fluid, so they're stiff, okay? Because there's fluid leaking out into the lungs on both sides, there's going to be patchy infiltrates, meaning when we look at chest x-ray, there's going to be patches of fluid that we're going to start to see on the chest x-ray. hypoxemia for sure, right? The lungs are filling with fluid, so the oxygen, the capillaries can't receive oxygen. Confusion is just from hypoxemia. Adventitious breath sounds, so the crepitations and crackles because of all the lungs that are, of all the fluid that's filling the lungs. So what can we do if someone's in respiratory failure? What diagnostics? Well, a chest x-ray we often see, whether it's bilateral pneumonia or ARDS, and we see fluid filling the lung spaces. An ECG, that's really just to help us look at the heart rate, the rhythm of the heart. Is it a sinus tachycardia? Okay. Sometimes it helps us determine if the person's had a heart attack, a STEMI or an NSTEMI. And that might be a reason why they have fluid backing up into their lungs and causing pulmonary edema. Right? Arterial blood gases can be very useful because they're going to tell us what's the pH of this in the blood, what's the PaO2, what's the O2 sat, and what's the CO2 level. Okay, so it just gives us lots of information about what's going on with oxygenation and the CO2 in the blood. Okay, so say someone comes in respiratory failure and we just don't know the cause. They're having a lot of difficulty breathing. They're short of breath. They're sweaty. Their heart is racing. They're breathing at 40 per minute. They can barely talk to us. And we want to treat them. Okay. Do we need to know the cause right at the beginning? No. It could be pulmonary edema. It could be a huge pneumonia. It could be a pneumothorax. It could be a massive pulmonary embolus. It could be a whole bunch of things. Okay. But what we need to focus on first is airway, breathing, circulation. Okay. So airway. Are they able to get air from their mouth to their lungs? Okay. So if there's an obstruction, say we hear wheezing, or we think they may have choked on something, okay, we need to open up the airway somehow. Okay, so they have massive swelling in their mouth from an abscess or from burns, and they have so much edema that we need to secure their airway with an endotracheal tube. Okay, once we're happy with airway and we think the airway is clear, okay, we can go on to breathing. What's breathing? Well, breathing is actually the lungs, right? So can we hear lung sounds on both sides? Are they clear on both sides? Or do they have reduced air entry of one lung compared to the other lung? If there's reduced air entry, what could that be from? Could it be from a pneumothorax because there's no air going into that side? Could it be from a massive pneumonia and there's no air going into that side? Okay, so we assess breathing by listening to the lungs and also by looking at their arterial blood gases and their O2 sat. Okay, we can assess breathing. So airway is getting the air to the lungs. Breathing is let's listen to the lungs and assess the lungs and see if there's anything that's occurring in the lungs that we can treat. Okay. Circulation is the cardiovascular status. What's the heart rate? What's the blood pressure? What's the capillary refill? All of those things in terms of the vascular system. Okay. So if it's an issue with airway and breathing, okay, let's see if we can get their oxygenation up. Let's put a nasal cannula on them. Let's put an oxygen mask on them. Let's put a non-rebreather on them. So we can just escalate the amount of oxygen that we want to deliver. And if that's not working, we may need to go to intubation and mechanical ventilation. Okay. Now, D and E, we won't spend too much time on it here, but D stands for disability, which is a neurological status, a neurological exam. Okay, are they talking? What's their Glasgow Coma scale? Can they move their arms? Can they move their legs? And E is environment and exposure. So we typically expose the whole patient to see if there's anything that we need to examine after we've done our ABCs, right? The environment reminds us not to keep them in a cold room. They're going to get hypothermic, and that can cause a lot of problems in terms of treatment, okay? So, so that's where the A, B, C, D, and E comes from, okay? And the whole idea is I need to maintain oxygenation of this patient, even if it means intubating and ventilating. The C, I need to maintain blood pressure and perfusion of all the critical organs, such as the heart, the brain, the kidneys. So if someone's hypotensive, we need to address that. If they're hypotensive because they're dehydrated, we'll give them fluids, such as normal saline or Ringer's lactate. If they're hypotensive because they're bleeding severely from somewhere, we're going to give them blood to replace the blood that they're losing. Okay. Okay, so let's just talk about some of these drugs. A lot of these drugs that you're looking at here is when we're looking to sedate someone and intubate them. So benzodiazepines, well, they can actually shut down someone's breathing. So someone might be really anxious while they're gasping for air and short of breath. So we would be careful not to give them too much benzodiazepines unless we've made the decision that, okay, let's put them to sleep and intubate them. And then, okay, let's use some benzodiazepines to relax them, okay, and to sedate them. A very powerful sedative is actually propofol. That is going to, we often use that to sedate someone and intubate them, okay, because you really have to be asleep for us to intubate you. No one is going to tolerate a tube going through their vocal cords if they're awake. They need to be be sedated. Okay. Now, on top of being sedated for a procedure such as endotracheal intubation, you need pain medication such as fentanyl or morphine. Why? Very painful condition. A tube going to the back of your throat is going to cause the gag reflex. A tube going through your vocal cords can be very painful, and then into your trachea. So we often give them benzodiazepines and IV opioid analgesics before intubating. Okay? So that's where those drugs come in. Corticosteroids. Well, inflammatory conditions, right? So someone is failing because they have severe asthma or severe COPD and they can't maintain ventilation or oxygenation. Well, let's see if we can get some of the inflammation out of their lungs with one of the corticosteroids. Methylprednisolone is IV. Dexamethasone can be IV or oral. Okay, so those are just steroidal anti-inflammatory drugs. The neuromuscular blocking agent would come in when we want to intubate someone, right? We want to paralyze the muscles in their neck, in their chest, to make our view very good while we're trying to get this tube into their lungs to then put them on a ventilator. So we use neuromuscular blocking agents to help us relax and paralyze all the skeletal muscles. Okay? And then, of course, antibiotics. Well, it just depends on what the condition is. If it's a pneumonia, absolutely, we're going to start IV antibiotics. So if someone went into respiratory failure because of a pneumonia, we're going to start IV antibiotics. If they went into respiratory failure because of a flailed chest, well, we're not going to start antibiotics, right? If they went in because of pulmonary edema from left heart failure, that doesn't need antibiotics. So it just depends on the condition. If it's an infectious condition, sure, we'll start antibiotics. Okay. Okay, so let's do the questions at the end of the chapter. So number one, a nurse in the emergency department is assessing a client who is in a motor vehicle accident. Okay. Findings include absent breath sounds on the left side, left lower lung, with shortness of breath. Okay, so you have absent breath sounds and you have shortness of breath. Okay. Blood pressure looks fine, 118 on 68. Heart rate is fast at 124. Respirations are fast at 38. The temperature is elevated, so 101.4. And the oxygen saturation is reduced, 92%. Okay, 95 to 100 is normal. Which of the following actions should the nurse take first? Okay, so this person is tachycardic and breathing fast following a car accident. So I'm thinking of some kind of traumatic event has occurred in the chest. Could be rib fractures, could be a flailed chest, could be a pneumothorax. So there's a number of causes that could be occurring, giving this person their symptoms and signs. So I'm going to revert back to my ABCs. What's the most important thing? The person needs to have oxygenation. And if their O2 sat is low, this isn't terribly low, but just for the purposes of this question, I'm looking to get a normal O2 saturation. So I need to get their O2 sat up to 95%. So they're going to need oxygen first. So obtain a chest x-ray? No, that's going to be later. Okay, not much later, but it's going to be later. Prepare for chest tube insertion? Well, I don't even know if they have a pneumothorax or a hemothorax, so I'm not going to prepare for that yet. Administer oxygen via high flow mask. Yes, I want to get their oxygen up to normal before I do anything else. Initiate IV access. We will do that, but does it have to be the first thing? No, their blood pressure is fine. Now their heart is definitely racing, so they could be bleeding from somewhere. But the first thing is airway, right? Airway, breathing, oxygenation. So it's going to be C. 2, a nurse is orientating a newly licensed nurse on the purpose of administering vecuronium to a client who has acute respiratory distress syndrome. Which of the following statements by the newly licensed nurse indicates understanding of the teaching? Okay, so if we're going to inject vecuronium, which is a complete muscle paralytic, we're definitely not doing it if the patient's awake, right? So it sounds like we're preparing to intubate this person because that's why we'd want to paralyze them. So they need to be asleep with sedatives such as benzodiazepines or propofol. They need analgesics such as IV morphine or IV fentanyl because this is going to hurt. And then we can give vecuronium. Okay, so this medication is given to treat infections. No, it's a paralytic. This medication is given to facilitate ventilation. No, it's a paralytic, right? So I'm really hoping that's not the answer here, and it is the answer. So it's not to facilitate ventilation, it's to allow us to open up, it allows for muscle paralysis, so we can actually get the endotracheal tube into the trachea and ventilate the patient with a ventilator. Okay, so this medication is given to facilitate ventilation. Well, it's used to paralyze the muscles so we can get an endotracheal tube in. Okay, this medication is given to decrease inflammation. No, that would be something like a glucocorticoid. This medication is given to reduce anxiety. No, that would be something like propofol, or more generally benzodiazepines would be used to decrease anxiety. So I guess I would have to go back and stare at B and say, well, the medication is given to facilitate ventilation. If the answer said this medication is given to facilitate intubation, well, I would definitely go for B. But I don't have a choice here because that's the only other semi-close answer. So it's going to be B. I wanted to mention one more aspect to question number 2. Sometimes if someone's on a ventilator and they're really fighting the ventilator in terms of they're taking breaths when the ventilator is trying to push air into their lungs, and there's just all kinds of, it's just asynchronous. So, and sometimes we just want to paralyze the patient and let the ventilator do all the work. Then we will put them on vecuronium and keep them on vecuronium potentially for a day or two to completely paralyze them. Don't forget, if you're on a paralysis, you have to be completely sedated and have pain medication because all this drug's doing is paralyzing your muscles. So in that sense, it would help facilitate ventilation while they're on the ventilator. Okay, so I thought about it a bit more, and B is the only good or decent answer there. Okay, 3. A nurse is reviewing the health records of 5 clients. Which of the following clients are at risk of developing acute respiratory distress syndrome? So acute respiratory distress is when the vessels in your lungs are leaky and they're leaking fluids into the lungs all over and you're getting pulmonary edema. Okay? So who could develop ARDS? So a client who experienced a near drowning incident. Absolutely. So if they've had fluid gone into their lungs and it's caused a lot of inflammation in the lung tissue that's caused leaky vessels, they could develop ARDS. A client following coronary artery bypass graft. I mean, it is possible to develop ARDS because what have they had done? They've had their chest opened like a clamshell. And that's a form of trauma, really. So could they develop ARDS and leaky blood vessels in their lungs, leading to stiff lungs? Sure. Okay. A client who has a hemoglobin of 15.1, no, nothing's happening there. There's been no trauma, there's no systemic inflammation, so no. A client who has dysphagia. Well, dysphagia is really just difficulty swallowing, right? That's what the term dysphagia means. So now we're into this assuming again. So if you have dysphagia, could you get aspiration? Yes, you get aspiration. Could you get pneumonia from aspiration? Yes, it's possible. And could you get ARDS, which is inflammation occurring, all in the lungs, causing vasodilation from a pneumonia? Yes, but there's a lot of assuming there. So that's probably going to be an answer, but that's a bit of a stretch. A client who experienced acute drug toxicity. So someone who's experienced acute drug toxicity could say they were unconscious and say they weren't ventilating well. Could they develop ARDS from the drug toxicity? Sure, it's possible. Say the drug toxicity was in the lungs itself. It caused inflammation of the lungs, and that caused leaky vessels in the lungs, causing ARDS. So that's possible. So it's probably going to be A, B, D, and E, but D is a real stretch because there's a lot of assumptions going on there. Okay. 4. A nurse is planning care for a client who has severe acute respiratory distress syndrome. Okay, SARS, so that's caused by a viral infection in the early 2000s when SARS came through. Which of the following actions should the nurse include? Antibiotics? No, because it's a viral infection that caused SARS, right? Provide supplemental oxygen? Definitely. If you have severe acute respiratory distress syndrome, you're likely hypoxic. So providing oxygen. Administering antiviral medications. Well, SARS was a virus, but there was really no effective antiviral for it. I think this is a bit of an unfair question too, because how could you know that from years later? So no, C is wrong. Administer bronchodilators. Yeah, if you have a viral infection of your lungs and bronchial tubes, could you be wheezing? Absolutely, right? So bronchodilators could be used. Maintain ventilatory support. Yes, some of these patients had to be put on a ventilator, and they needed support of their ventilation. Okay, so A's wrong, B's right, um, D's right, and E's right. Okay. Last question. A nurse is caring for a client who is receiving vecuronium during mechanical ventilation. Okay. Which of the following medications should the nurse anticipate administering with this medication? So you definitely need, this person definitely needs to be sedated, right? So some form of sedation. They cannot wake up and be paralyzed. That would be horrifying. Um, so so midazolam is a benzodiazepine. It's definitely going to be part of the answer. Furosemide is to clear fluids out of the lungs in pulmonary edema. That's not mentioned here. So you don't need that to use vecuronium. Famotidine is an H2 blocker for GERD. Um, that doesn't need to be used for mechanical ventilation necessarily with vecuronium. Dexamethasone is an anti-inflammatory corticosteroid. That doesn't necessarily have to be used. But fentanyl. So fentanyl is an analgesic, right? You have a tube down your throat. You're on a ventilator. That's going to hurt a lot. So fentanyl for the pain, a benzodiazepine such as midazolam for the sedation while giving vecuronium.